The following episode is brought to you by the American Urological Association. Today's episode is all about what you can expect from our newly designed full-day hands-on skills training at AUA2025. Listen as Drs. Thomas Chi and Robert Sweet discuss Masterclass, Renal Access and Interventions, an all-new interactive training offering skills in percutaneous renal access and image-guided renal interventions. The early bird deadline for hands-on skills training has now been extended. Spaces are limited, so register by March 24th to save with the early bird discount.
Good afternoon. My name is Jay Rahman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series. This podcast is one of several that we are doing to highlight some of our annual meeting content. Specifically, we're going to be talking about some of the nuances of our hands-on skills training course, which is a masterclass in renal access and renal interventions. Joining me today are our two co-directors of the course who have done a great job both now and in the past in helping run our hands-on skills programming. Dr. Rob Sweet, who's professor of urology at the University of Washington, and Dr. Tom Chi, who's professor and chair of urology at the University of Alabama in Birmingham. So first of all, Rob, Tom, thank you so much for joining. Obviously, we're coming up to about 6 weeks until the annual meeting, so I look forward to seeing you both there in person.
My pleasure. Thanks for having us.
So, we talked even offline before we got started, but maybe just talk a little bit about the whole concept of renal intervention, maybe the role of the urologist, and sort of, I think what is a little bit of a paradigm change where historically a lot of urologists relied on interventional radiology colleagues to really do this, and then we would come in and do the specific procedure. And I think there's been sort of an evolution in trying to empower urologists to really be able to be more comfortable and own this entire space, perhaps soup to nuts. Maybe let's start off, and maybe if you could both give me your perspectives on that broad comment.
Yeah, I mean, I'll get started, Tom. I think that you really hit the nail on the head. The issue really is that the patients are going to do better with a lot of with percutaneous stone procedures if we expand our technical skills to be able to do these procedures. The data has shown that. And one of the things I'm very proud of, and I don't know if we're the only reason, I'm sure we're not the only reason, but if you look at the data, more and more urologists are getting their own access for PCNLs slowly. It's not like a huge jump, but I think we've made a dent as a field. And certainly I don't think it's being driven by reimbursement, because you don't get reimbursed that much more for getting your own access. But that patients are doing better, and I believe urologists are investing in their skills to be able to do that for stone procedures and also for potentially renal biopsy, which we're offering as well. Tom?
Yeah, that's a great comments. And, the things I'd add on there is that I think it's a very exciting time, I think, actually, for renal access, because, traditionally, while not where most urologists would rely on interventional radiologists to puncture something in the kidney, nowadays we have so many new technologies, so with fluoroscopy, there's laser darts, there's endoscopic combined intrarenal surgeries. There's many techniques to get you to the kidney. There's ultrasound. I'm a big fan of ultrasound. I'm a bit biased towards ultrasound. But there's so many new technologies now that enable urologists to take that most important portion of every procedure and then use it to benefit your patients. I think it's huge. The unbundling that happened, I think, with coding, like you won't get reimbursed a ton, but you do get reimbursed now for that procedure. And so that's favorable. So everything's kind of lined up. And so, our goal with this course is to try to facilitate learners to get that skill in their hands. And it's also a time when you can do things like biopsy kidneys, you can put nephrostomy tubes in, you can do renal access for PCNL. So there's many different applications nowadays. So it's an exciting time for endourology.
Sure. And I think, as you both sort of said, if you just think about sort of PCNL, percutaneous surgery for stone disease, it's interesting. Yes, financially, with the unbundling, yes, you do make some more, but it's not exponentially more. But I would argue very much, and I think our experience in our place is the workflow is much more seamless, right? When I started here, 15, 18 years ago, patients would come in, they would have their nephrostomy tube or nephrostomy access by the interventional radiologist the day before. Often, maybe they'd spend the night or they'd get in the morning, and then you'd have to sort of juggle things around to get the OR schedule. Then maybe the access wasn't in the calyx of interest. And so then somebody would come up and you have to re-access the kidney. And so, although the finances aren't so much more lucrative just from a simple payment structure, I do think that the workflow is dramatically more patient-centric and probably actually saves a hospital, a health system, a lot of money if you just think about patient in a room or in an OR time. Maybe your thoughts on those comments.
No, I completely agree. And I can't tell you how many times after studying the CT scan ahead of time and all the data we have, you come up with this is the plan. And I'll tell you, with the endoscopic combined, that's really made a big difference too, because you go up there and you look and stones move around, things change from that CT. And maybe 20% of the time you're choosing a different calyx because the angles, once you're in there and you see everything, or you move stones around and you get that optimal calyx that gets you everything, and it isn't always the one if someone else has put a tube in, it's oftentimes not that access. And you're stuck either re-getting access or using it and having to get a second one or coming back and doing a cleanup ureteroscopy. Again, like you said, more resources and not as smooth of a case, certainly.
Yeah, I couldn't agree with you more, Jay. I mean, that patient-centric model where you've got one integrated, smooth workflow and patient experience, I think is huge. So just for patients to be able to go one-stop shop, go to sleep one time, get everything done under one anesthesia with one surgeon who knows them tip to tail, that's a massive benefit, I think. Massive benefit for patients.
So Rob, you mentioned a little bit, but maybe we could just, talk a little bit. Obviously, I think fluoroscopy is sort of, something that almost all urologists are very comfortable with. You mentioned a little bit the endoscopic combined. Tom talked a little bit about ultrasound, maybe just at a high level. I realize everyone's skill set's a little bit different. Everyone's approach is a little bit different, but maybe talk a little bit about, maybe for both of you, maybe the pros and the cons of all these different ways, maybe to get renal access and how you think about it as you're looking at patients or you're thinking about teaching it to people that are getting into this space.
Yeah, I mean, it's really like, what type of a practice do you have? Or do you have the type of practice where you're an endourologist, you're focusing on stones, and so you're doing a lot of volume? That's a factor for sure. And how many resources are you going to put into making this? PCNs are complex operations, and centers of excellence are going to do them in a much more smooth way, I guess you could say, than if you're doing 5 a year. And so, I mean, can you possibly do everything? It can be tricky. For me personally, in my practice, and I only do stone procedures pretty much at this point in my career, and I still do a lot of PCNLs. I probably do between 1 and 4 a week. It's ranges, but I think the endoscopic combined aspect, whether you're using ultrasound or you're using fluoro, it was such a game changer in my mind in so many ways, in every step of the case, from the access component of it, being able to watch it go in, to the dilation step where you're exactly where you want, you're not too far, you're not short, watching your sheath going in, setting up the case at the beginning so stones in hard places are now in easy places before you even dilate and you're on the clock with bleeding, and then exiting. Okay, checking all those calyxes, looking at that calyx right next to the sheath, which you can't look at from any other way than from below. And I will often find stones there, and you take them out right there and then from below at the end of the case, quickly clearing the ureter at the end of the case, which everyone should do after every single PCNL. I mean, every step, you may not use that access from below for access. Doesn't matter. It still helps you in all these other steps of the procedure so that it's safe and you have a better stone-free result, and it goes smoothly. So that was a game changer. Tom, she has been such a champion for ultrasound, and he came to the University of Washington and taught me and my colleagues how to do ultrasound, and And we do that. My two colleagues, that's almost all they do is ultrasound. I probably do more fluoro than they do, but having all of those skills just is really, really helpful.
And I would say
about
that
the ultrasound. Yeah, talk to us about that a little bit.
so one of the things that we found has been a real appeal for ultrasound is really about learning curve. So when people first came up with techniques to get access into the kidney, and they were really centered around fluoroscopy, folks have published that the learning curve to be able to become really good at that can be 100+ cases, and so it's a big barrier of entry. And so I think that's what drove a lot of urologists to rely on interventional radiologists to do the access part. And what we're seeing with these new techniques, especially ultrasound, you can learn ultrasound, the basics of ultrasound, to be able to stick a needle into the kidney with 6 to 10 cases. And so I think that kind of brings the fun back into the endourology factors. And so at least in our hands, for the learners, what we found, and we've published this, is that learners can actually pick up on the techniques that we teach at this course. So Rob and I have been doing this course now for a few years, and learners are excited and it's fun. And so people will come in and be able to kind of get a primer. And then one of the other nice things about the course is that you get a whole smorgasbord. So you don't just see one thing, you're going to see the whole spectrum of different techniques to get in, from ultrasound to fluoroscopy to endoscopic visualization, and then different techniques of fluoroscopy and using handholds for ultrasound. So you've got the whole spectrum of stuff that you'll get exposed to at a course like this. And then something will resonate with you. I think it's usually what I find with the learners is that they'll be like, oh, I actually like this the best. They're all tools, and some of them that just feel like they'll work with your hands a little better, work with your brain a little bit better. And so the opportunity to be able to try lots of different stuff on models is really cool. And then to be able to bring what makes sense to your practice back so you can sharpen those skills and benefit your patients. I think that's how I think about putting it all together in a course like this.
Tom, it's interesting now that, our site for our fellows and residents, but especially our fellows, have been learning both ultrasound and fluoro. You're absolutely right. They pick up ultrasound way quicker. Mm-hmm. So they're able to do ultrasound early in their fellowship, and they're able to get access. Fluoro takes them longer to understand. It's that complex concept of parallax, right? Where they're working, that needle's in a 3D environment, and they're getting 2D data from that X-ray fluoro. And that's hard. I mean, it's a brain trick, and we have tricks of teaching, and this course has done that, and we'll continue to train those skills. I think it's important to have both.
Tom, maybe one sort of follow-up question in the realm of ultrasound, and I'll be honest, I haven't done a PCNL in many years, but I recall under fluoro, one of the very comforting things was always seeing, at least fluoroscopically, your wires going down the ureter, so you knew where you were going. Maybe talk a little bit, as you teach ultrasound. There's access to the kidney, but then there's sort of the second component, which is having the comfort of knowing, I think your wires are going down. So as you dilate, you know that you've got enough, I guess, counter traction with the wire down the ureter that it's dilating the track and the direction you want to go in. Is this, how do you teach that maybe? And is this a place where the combined approach maybe helps you visualize sort of that trajectory in the course of that? Maybe talk about that for a moment.
Yeah, I think that's a good comment, in that many people will strive to get the wire all the way down the ureter. And it's true, when you have through and through access from the kidney down to the bladder with a wire that goes all the way antegrade down, it gives you great safety and security, which is terrific. With you doing ultrasound, the ultrasound machines now are very good. And so you can see needles pretty well. You can see pretty much any wire pretty well. It's hard to see some parts of the ureter. So if that's something that makes you feel comfortable that you really want to get, that's when I would highlight where all of these are tools, and not necessarily that you have to do only one in order to be successful. They're all tools, and our goal is to get you to the finish line so that you can be successful with your patients. And so if I was a person that really wanted to have the wire all the way down the ureter, I might use ultrasound to get my needle in, and then to get my wire into the kidney. And then maybe I'll flip over to fluoro and then use fluoro to get my wire all the way down the ureter. Or to your comment earlier, Jay, you've got to scope up from the bottom. And as Rob mentioned before, that gives you great comfort. People will lasso the wire and then bring that down the ureter. Or I think—
And we teach these skills in the course.
Absolutely. And I think Dr. Klayman, Ralph Klayman, calls it the St. Petersburg technique, where you stick the wire through the scope, antegrade, down through the scope all the way up
through the
urethra. So there's lots of different ways to kind of
Sure.
get to the finish line.
We've talked a lot about sort of percutaneous access as it pertains to stone disease. I think another thing that both of you mentioned at different parts is ultrasonography for renal mass biopsy. And obviously, I think there's more interest in that over time. I think if you look at the data, persons being diagnosed with kidney tumors are getting older and older. They're more comorbid. Risks of surgery are greater. I think we still take out a lot of benign renal masses, and there's a push towards maybe trying to move that so that we have better confirmation, much as like we do for almost any other disease, right? You have a biopsy before you move on to more radical surgery. Sort of talk about maybe this course using the framework of ultrasound to sort of empower people to be able to maybe take that next step when you're confronted with these renal masses, renal tumors. Talk about that.
So I credit Jamie Lamon. So Dr. Lamon over at UC Irvine, who's the chair of urology there, he's been a real pioneer in this space. And I think that the same argument around, what's good for your patient, because a lot of these patients, they come to us with the diagnosis of kidney cancer. And then if you've got to schedule them to go get a biopsy with, radiology or interventional radiology, it's another step for the patient. Whereas if you make the diagnosis and you've got the setup, and they've got a terrific setup that he has in his clinic, where patients can go straight into the procedure rooms of the clinic themselves and get the biopsy done right on site. And so it's another way of just integrating the patient experience flow, which I think is a real benefit. And so nowadays, with the availability of biopsy guns that you can use in your office and ultrasound machines that are so good, they've got needle guides on them too that make it really easy. I've been down to visit him, and it's a masterful workflow to be able to just have your patient in there, get the biopsy all done, and the patient really benefits from that.
So maybe talk a little bit and maybe walk me through some of the course. I think that, the first part of it is, nobody wants to come to a hands-on course and spend hours in lectures or didactic. So talk maybe about that first part, which is what you have both done to try to get the hands-on, really hands-on, and what you do with all this other information, which is certainly very valuable in a base framework, but maybe not the best way to spend in-person time together. Talk about that.
Yeah, I mean, Tom and I are, coming at this in a joint program this year with years of experience with these courses. And you're right. I mean, they don't like, having lectures take up the whole time. And so one of the big changes is it's a whole full day course. There's a lot of material. It's for a full day rather than 2 half days, 2 separate courses. We've pretty much put almost all of our just core lectures as virtual didactic sessions. Let people do that on their own ahead of time. And we have outstanding topics on ultrasound, fluoro, mini PCNL, positioning of the patient, either in supine or prone position, exit strategies and complications, renal biopsy, little technique. It's very technique driven, the whole course. So endoscopic combined techniques, like we were just talking about, St. Petersburg versus lassoing the wire, just basic ultrasound techniques, and kind of a combination of all those different things. So those are all now lectures. Radiation safety, which we've done every year, which is a benefit of the ultrasound, and either whether you can use it completely as a solo methodology or modality, I should say, or in combined. Either way, you're going to decrease your radiation exposure to your patient, to yourself, and to your team. So that's good. And the hands-on components of this, we've really expanded the amount of time that they're going to get access to. Mini PCNL station. There's those tricks, as I mentioned, for endoscopic combined, percutaneous access using fluoro, percutaneous access using ultrasound, and basic ultrasound, kind of we call knobology and imaging techniques. So all those are hands-on. So almost the entire course is hands-on this year.
And as Rob mentioned, we've been fortunate to be doing this course for a number of years, and it's really been an evolution over time as we listen to the folks who come and the learners to try to figure out, okay, what kind of worked well and what kind of didn't work well. And that's one of the things that really has come out of people's feedback is that, when we come in to do a hands-on course, we want to have our hands on something. And so by flipping the classroom and having a lot of the coursework done ahead of time in terms of the core lectures, this way people are showing up and they're kind of ready to go right at the stations. And so the pre-recorded work is, we went out and really found ourselves the most dynamic lecturers out there to give the content ahead of time. And so people can look at that content, kind of absorb it, come with questions, we'll talk about cases, and then the bulk of the time really is hands-on. And so one of the things that lots of studies have shown is that, there's not one perfect model for any single thing. And so, one of the models that Rob here developed in terms of teaching fluoro, that's on there, but we also have a different model for ultrasounds. We have actual patient models for learning ultrasound, kind of the bedside and optimizing imaging. So by using many different types of models to teach these hands-on skills, when you come to the course, you're really putting your hands on many different things and really trying to optimize that time. So we know it's a big investment by people to be there. We want to make sure that you leave with as much hands-on training as possible.
And the other thing we're doing too, is yes, there's a ton of hands-on, but at the end, it's nice to see them with some sort of index cases. And so we're going to have a town home, kind of take-home Pearl focused, case-based, interactive session with the group. We'll bring some cases in that say, okay, here's a case where ultrasound was really helpful, or this is where there's no way we could have gotten this done unless we did endoscopic combined. Those types of things, and making them think about, okay, how am I now going to apply what I just learned to my practice?
What's the, just from a foundational aspect for somebody that's coming in, maybe a real simple question, who is this course ideally geared for? The true beginner, maybe somebody that's really towing the water, somebody that maybe has a practice but wants to refine. Maybe they are doing PCNLs, but they're not getting their own access, but they know some of the fundamentals. What do you both envision is sort of the sweet spot for the attendee?
I think the answer is yes. The reason I say that, beginners get something out of this. Do they automatically go and they take? We actually looked and studied the take rate. It's pretty high for this course. But then we also see people that are sort of getting their feet wet. They've already kind of done some cases. They may do all fluoro and they're going to learn ultrasound. They're going to learn biopsies. They're going to learn something. And I'll tell you, I do tons of these cases every year. I learned something from this course. So I think there's something in it for literally every level of provider. Tom, I don't know how you feel, but
I think also one of the things that's a really big advantage that they're pretty the spots go fast, and getting in the spot, we don't want to make it too big of a course because we want to make sure that everybody has a lot of hands-on time with the instructors. And I think the instructors are key because we've gone out of our way to really find the best teachers that we know for each of these stations. And so, to Rob's point, when you're in there and you're doing a hands-on with an instructor and you only have 4 or 5 people at the station with you, you're getting a lot of hands-on time, and the instructors are just wonderful. And so they're spending time to try to figure out, okay, what is your skill level? So even though you might have 4 people of different skills at that same station, they're going to cater their teaching to meet you where you're at. And I think that's one of the things that really makes it a valuable experience for people, because the instructors, it's really hard to get a cast of characters like this that we have, folks from all over the world, all over the country, just amazing educators.
Just to that point you made, talk a little bit about how many instructors do you have? Like, what's the ratio, ballpark? You may not have any, but is it 1 instructor to 4, 1 instructor to 5, 3? What's your ballpark ratio that you've aimed for in this course?
So our target is like 1 to 4 to 5. So 1 instructor for 4 or 5 learners at each station. And, it's always a balance because we want to give access to as many people as possible to come to these courses, but we want to make sure that it's a high value for people that do attend. And so that's about the number that we find, people really kind of optimize the amount of time they have there, and everybody's learning. And so that's about the right number for us.
It's interesting. Rob and I were chatting briefly before we started the podcast that, one of the things that we're trying new this year is obviously doing this on a full day before the annual meeting really begins. And obviously, as you both know, but many of our listeners may or may not know, obviously these courses that we host are all product agnostic, meaning it is meant to really teach the armamentarium that's available. But of course, I'm assuming everybody goes back to their individual hospitals and they have certain things that you can't get everything. I think we all wish we could get everything, but the reality is every hospital has a certain amount of equipment. And I think, what we're really hoping is to use these courses like this as a foundation for people to understand, figure out maybe what they like, and then maybe to take advantage of all of our exhibitors who are obviously very valuable partners and have great sort of resources in the exhibit hall. But as the meeting gets rolling the next day and beyond, maybe go to A, B, or C because your hospital has A, B, or C, and figure out in that environment what they can do, what they need to go back and say, look, this is what I need to get this off the ground. Maybe, your thoughts on that. Obviously, it's a new sort of thought and idea, a new structure to how we do hands-on courses, but appreciate either of your thoughts on that.
Yeah, industry's always supported the courses with materials, and we do stay neutral. And there are different, if you're needing wires, you're needing needles, or you're needing scopes. They know there are lots of different options for things. I think the one station that probably highlights what you're just describing the most would be mini PCNL, because that is an investment in a very specific set of equipment, and there's a couple of vendors for it. But most of and some of the other things, like for positioning, for example, when we teach split leg prone, which is one of the getting the table adapters, like the split leg table, things like that are things that help them go and find vendors that might be able to support them in being able to do these cases. But yeah, the mini PCNL one I think is really helpful because it lets them. We actually invite multiple different vendors so that they're able to try to different scopes, and they have slightly different techniques even with them as far as using suction. So I think it really does highlight what you're describing.
Yeah, it's definitely one of our goals, Jay, to try to get people exposed to a wide arsenal of products, whether they might be in your hospital or not, so that, it's a chance for people who are coming in to join the course to also think, actually, I like that wire a little bit better, or oh gosh, Rob uses that particular sheet. That's kind of interesting. And so those are opportunities for people to think, oh, well, maybe I would like to change things up, or I actually like what I have. And so it's also an opportunity to go down to the exhibitor hall and then figure out, what you might want from there. So all those touch points are there, and industry's been really terrific collaborators for these courses. So we do remain agnostic, but very grateful for their participation and support.
Well, that's great. Well, I really want to thank both of you. I think we've sort of paired up your courses, and they've been the ones that I think have sold out almost every year over the last 3 or 5 years. At least, I've been doing this for 4, and every annual meeting, they've always done extraordinarily well. Obviously, I think it's a credit to both of you and the effort and time you put in. And I think it'll be another great meeting, great course. And I do very much appreciate all your efforts in advance.
Thank you, Jay.
Hey, thanks so much, Jay. Thanks for having us.
Yeah.
To our listeners, there's still time. We're about 4 weeks out from the annual meeting. You can certainly go to AUA2025.org, obviously register for the meeting, and then the opportunity to register for any of our hands-on skills trainings or any other offerings within the annual meeting. Rob, Tom, I look forward to seeing you hopefully soon, probably in the next 4 to 6 weeks. And again, my pleasure to have you both on this podcast today.
See you soon, Jay.
Our pleasure.